So today all about malignancies. First is renal cancer. Most common histological type is clear cell. It is 85% of the primary renal tumors. Usually it occurs in older age who are smokers, and then tuberous sclerosis, von Hippel-Lindau's disease, and adult autosomal polycystic kidney disease are all predisposing conditions. Typical triad of the symptoms is fever, loin pain, hematuria, and palpable mass. Then there are paraneoplastic features as well. Tumor may secrete erythropoietin and then it can cause polycythemia. Then parathyroid hormone related peptide can be released. Renin can be released. ACTH can be released. 25% of these people they have metastasis at presentation. Then paraneoplastic hepatic dysfunction syndrome. This is also called Stuffer syndrome, in which there is cholestasis and hepatosplenomegaly, and it's thought to be secondary to increased level of interleukin 6. Then varicocele can be present. Majority are left-sided and they are caused by tumor suppressant gene. Predisposing factors are smoking, advanced age, then after that tuberous sclerosis, von Hippel-Lindau disease, and adult polycystic kidney disease. So briefly describe staging. T1 tumor is less than 7 centimeter and is confined to kidney. T2 is greater than 7 centimeter, but again confined to kidney. T3 it involves ipsilateral perinephric tissue, but it does not involve adrenal gland, and it does not go beyond gerota fascia. While in T4 it invades beyond gerota fascia. So management, if it is an initial stage and it's less than 7 centimeter in size, partial nephrectomy can be done. Then alpha interferon and interleukin 2 can be used to reduce the tumor size. And finally, tyrosine kinase inhibitor like sorafenib may be shown to have some effects. Then is testicular cancer, which is very common malignancy at the age of 20 to 30 years. And there are two type of tumors, germ cell tumors and non-germ cells. Germ cells tumors, they have two subtypes, seminomas and non-seminomas. Non-seminomas include choriocarcinoma, yolk sac tumor, and teratoma and embryonal carcinoma. While non-germ cell tumor, it include Leydig cell tumor and sarcoma. Now, the peak incidence for teratoma is 25 and for seminoma it is 35. And the risk factors are infertility, cryptorchidism, mumps orchiditis, and family history and Klinefelter syndrome. Now, how it presents, it can be a painless lump, and then sometimes there can be pain and hydrocele and gynecomastia. Then we have to see that which tumor markers they produce. Seminoma, it produces beta HCG germ cell tumors, and the Leydig cell dysfunction, it leads to both disturbance in testosterone production and rise in estradiol. While Leydig cell tumors, they secrete more estradiol, and androgen precursors, they convert them to estrogen. Exam question is that which tumor marker is produced by a seminoma? So it is beta HCG. Seminoma means semen, and it makes the lady pregnant, and then beta HCG is produced. So you can remember like this. And then HCG may be elevated in around 20% of the cases, while on the other hand, the non-seminomas like teratomas and choriocarcinoma and embryonal carcinomas, beta HCG can be elevated, but usually it is alpha fetoprotein. LDH is elevated in around 40% of the germ cell tumors. So take home message is seminoma, they releases beta HCG, while non-seminoma germ cell tumors, they produce alpha fetoproteins. And the other tumors, Leydig cell tumors, they produce estradiol. So this was all about. So take home message is that these are the tumors of young males, and there are two type of tumor, germ cell tumors and non-germ cell. Germ cell contains seminoma and non-seminoma. Seminoma produces HCG. Non-seminoma, they include teratoma, then choriocarcinoma, embryonal and yolk cell tumors. And these tumors, they produce alpha fetoprotein, although they may produce beta HCG as well. Then non-germ cell tumors, they actually include basically teratoma and sarcomas, and these tumors they produce alpha fetoproteins. So they usually present with a lump that can be painful or painless, hydrocele, and then after that they can produce with different release of different secretions. So this is a childhood kidney tumor which is called Wilms nephroblastoma, and it has good prognosis luckily. Although 20% of the people they have metastasis. So children under 5 years of age they are more prone to have this tumor, although median age is 3 years. It has got association with Backward-Widerman syndrome, and it can be part of Weger syndrome, in which there is an iridia, genitourinary malformations, and mental retardation. Hemihypertrophy, about one-third of cases they are associated with loss of function mutation in Wilm tumor WT1 on chromosome 11. As far as the features are concerned, again, same as that of adult renal cell tumor, that is fever, loin pain, hematuria, abdominal mass, anorexia, and so patients' other features are anorexia, fever. They are unilateral in 95% of the cases, but metastasis they are present in 20% of the patients. Children with unexplained enlarged abdominal mass, they should be referred. It can be Wilms tumor, and it needs review within 48 hours. Management is nephrectomy, chemotherapy, and radiotherapy, but fortunately, prognosis is so this is the second most important topic, second last most important topic. Usually questions they come, and usually when we do transplant, we do HLA matching, and the HLA matching system or histocompatibility complex is encoded by chromosome 6. It has got two groups. One is class 1 antigens, which are got A, B, and C, and class 2 has DP, DQ, and DR. When HLA matching for renal transplant, the relative importance of the HLA antigens are that DR is more important than B than A. So I have remembered it as DR stands for doctor, B is bachelor, A for arts, bachelor of arts. Bachelor of arts is called in Pakistan. So doctor B A. Then graph survival is shown that for cadaveric transplant, survival is little bit low. 1 year is 90% and 10 years is 60%, while in case of living donors, it is 95% and 75%. So, other than infection in transplant, and then UTI and urine leakage and thrombosis, there can be hyperacute reaction which occurs within hours, and it is because of antibodies, that is B cell or humoral immunity, and it is an example of type 1 hypersensitivity. There is widespread thrombosis in the graft vessels, ischemia, necrosis, and the treatment is the immediate removal of the graft, and no treatment else is possible. Then hyperacute rejection is within less than 6 months. It is because of cytomegalovirus, and it is associated with increased creatinine, pyuria, proteinuria, and causes are cytomegaloviral infections. And this it can be reversible with steroids and immunosuppressants. So this is acute graft failure. Then after that is chronic graft rejection, which occurs after 6 months, and in this both humoral and T cell mediated immunity is involved. In hyperacute rejection, only humoral immunity is involved. Then acute rejection, in which T cell immunity is involved, and it's because of cytomegalovirus, in which there is raised creatinine, pyuria, and proteinuria, and the treatment is by immunosuppressant and steroids. Then chronic, it occurs after greater than 6 months, and usually there is a return of the original disease. Then the drugs which are used in when we transplant kidney, these are cyclosporine, tacrolimus, sirolimus. These are the drugs, and usually side effects of these drugs is that they produce hypertension, they produce hyperlipidemia, and they produce hyperglycemia. So we have to keep a check over all these complications. So in bladder tumor only, this thing is important, that which are the predisposing factors for transitional cell CA and which are the predisposing factor for squamous cell CA. For transitional cell CA, I have made a mnemonic circ, which is a tablet which is used in benign positional vertigo. S, it stands for smoking, E for exposure to aniline dye, R for rubber, and C for cyclophosphamide. And of course, squamous cell carcinoma, it is predisposed by schistosomiasis and smoking. Now, a last tumor is prostatic carcinoma, and prostatic carcinoma, it is if it is of initial stages, that is T1 and T2, then we observe the patient. We can do radical prostatectomy, and then we can do radiotherapy, which has its own side effects. Like it can lead to cancer of colon and other part of alimentary canal. While if it is T3, T4, first of all we give hormonal therapy, then we can do radical prostatectomy, and finally we can give radiotherapy. As far as hormonal therapy is concerned, first of all we have got gonadotropin releasing hormone agonists, Zoladex. So these agonists, first of all, they increase testosterone level. This flare of testosterone is for 2 to 3 weeks. In order to combat that, we give anti-testosterone or anti-androgens. Then we have got gonadotropin releasing hormone antagonist, Degarelix, and with this we do not have this flare up of tumor. As far as anti-androgens they are concerned, some of them they are steroid in nature, while some of them they are non-steroidal. Steroid nature anti-androgens are cyproterone acetate, while non-steroidal is biclotamide, which actually blocks estrogen receptors. While on the other hand, cyproterone, it prevents basically binding of androgens to the receptors. Then RB-ratin, it actually decreases synthesis of testosterone. And finally, we have got bilateral orchidectomy. This is the last option which we can do. Thank you.